Welcome to This Week in Pulmonary. This week we're covering 10 notable papers spanning advances in lung cancer screening and oncologic genetics, novel management strategies for chronic obstructive pulmonary disease and asthma, and critical insights into acute respiratory failure and infection control. Let's dive in. We begin with 3 major publications in the Journal of Thoracic Oncology that reshape how we think about lung cancer risk, screening, and treatment. First, a major challenge in lung cancer screening programs is helping active smokers quit. In the Italian RISP trial, researchers evaluated the use of Cytisine, a smoking cessation aid, within a lung cancer screening cohort of over 10,000 participants. Among the current smokers, over 45% entered a cessation program, and nearly 39% of those accepted Cytisine treatment. The results were striking. The smoking cessation rate was just over 50% among Cytisine users, compared to only about 8% for those receiving counseling alone, representing a massive 14-fold increase in the odds of quitting. While common side effects included nausea, insomnia, and abdominal discomfort, the efficacy and safety profiles were similar in older adults aged 65 and older, though women experienced more abdominal discomfort. Moving from screening to genetics, a systematic review and meta-analysis of 28 studies evaluated the prevalence of inherited genetic risks in lung cancer patients. The researchers found that approximately 8% of lung cancer patients harbor pathogenic or likely pathogenic germline variants, with the highest frequencies occurring in DNA damage repair genes like BRCA2 and ATM. Interestingly, a younger age at diagnosis and non-Asian ancestry were significantly associated with a higher prevalence of these genetic variants, which could help clinicians better identify patients who might benefit from genetic counseling. Finally, in patients already diagnosed with driver-positive non-small cell lung cancer, a large-scale cohort study investigated the clinical impact of methylthioadenosine phosphorylase, or MTAP loss. Found in about 10% of patients, MTAP loss was highly co-deleted with CDKN2A and was strongly associated with advanced disease. Crucially, driver-positive patients with MTAP loss had significantly lower response rates and shorter progression-free and overall survival when treated with targeted therapies, particularly those with EGFR mutations receiving third-generation tyrosine kinase inhibitors. This establishes MTAP loss as a robust adverse prognostic biomarker that may warrant alternative combination strategies. Next, we turn to chronic airway diseases, where new evidence highlights both pharmacologic and non-pharmacologic interventions to improve patient outcomes. In the Annals of Internal Medicine, a review of clinical trials evaluating macrolides for asthma management confirmed that, compared to placebo or standard care, long-term macrolide therapy for up to 48 weeks successfully reduces severe exacerbations and improves overall symptom control. For patients with chronic obstructive pulmonary disease, risk stratification and physical rehabilitation remain paramount. Another publication in the Annals of Internal Medicine highlights the utility of the Bliss score, demonstrating that this clinical tool effectively predicts the risk of acute respiratory hospital admission over a 2-year period in adults with chronic obstructive pulmonary disease. On the rehabilitation front, a randomized controlled trial, 8-week home-based training program. Patients with stable chronic obstructive pulmonary disease performed high-intensity inspiratory muscle training twice daily at their highest tolerable intensity. This short high-intensity program not only significantly increased maximal inspiratory pressure, but also led to beneficial shifts in cardiac autonomic function, including increased parasympathetic activity and reduced sympathetic activity. These physiologic changes translated to real-world benefits, with patients achieving an average 31-meter improvement in their 6-minute walk distance and substantial improvements in their self-reported health status and symptom scores. Our final theme addresses acute respiratory care and infection control in vulnerable populations. In the Annals of Internal Medicine, a trial evaluating oxygenation strategies in acute hypoxemic respiratory failure reported that high-flow nasal oxygen therapy did not reduce 28-day mortality compared to standard oxygen therapy. This highlights the ongoing challenge of managing severe hypoxemia and suggests that high-flow oxygen, while comfortable, may not offer a survival benefit in all acute cases. Meanwhile, a prospective multi-center study in respiratory medicine examined how obesity affects sepsis-associated acute respiratory distress syndrome under different diagnostic frameworks. Using the traditional Berlin criteria, Obese patients had a much higher risk of developing acute respiratory distress syndrome, but they paradoxically demonstrated a lower 90-day mortality rate than normal weight or underweight patients. However, when the researchers applied an expanded diagnostic definition that includes patients receiving high-flow nasal cannula therapy, the incidence of acute respiratory distress syndrome was still elevated in obese patients. But the classic obesity paradox mortality benefit completely disappeared. This suggests that while obesity drives pulmonary susceptibility, it does not confer a universal survival advantage in modern, broader cohorts. Lastly, managing respiratory outbreaks in long-term care facilities is a constant winter struggle. A cluster randomized trial published in JAMA Internal Medicine evaluated the impact of on-site point-of-care multiplex polymerase chain reaction testing in nursing homes. While the rapid testing did not change the overall number or size of respiratory outbreaks, it significantly improved clinical management. Facilities using point-of-care testing had higher viral testing rates, detected cases more accurately, initiated antiviral therapy for influenza 2.5 days faster, and successfully reduced emergency department transfers, avoiding an estimated 4 hospital transfers per 100 beds. If you only have time for one paper this week, make it the Italian RISP trial, which demonstrated that adding cytisine to smoking cessation counseling in a lung cancer screening program achieved a 50% abstinence rate. This study provides robust practical evidence that integrating cheap, effective pharmacotherapy directly into screening workflows can dramatically improve cessation rates, even in older adults who have historically been difficult to help. Here are the key takeaways from this week in pulmonary. First, integrating cytisine into lung cancer screening programs can achieve a 50% smoking cessation rate, offering a highly effective, safe option for active smokers, including those over age 65. Second, roughly 8% of lung cancer patients carry pathogenic germline variants, with higher rates seen in younger patients and those of non-Asian ancestry, suggesting a lower threshold for genetic testing in these groups. Third, point-of-care multiplex viral testing in nursing homes does not shrink outbreak sizes, but it speeds up influenza treatment and safely reduces emergency department transfers by about 4 per 100 beds. Fourth, the survival benefit often attributed to obesity in acute respiratory distress syndrome is absent when using modern diagnostic definitions that incorporate high-flow nasal cannula use. And fifth, an intensive 8-week inspiratory muscle training program for chronic obstructive pulmonary disease significantly improves both cardiac autonomic function and functional walking distance. That's your roundup for this week in pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.